We see blood all the time, right? We know it's vital. But, how much do we really understand about this incredible fluid, this stuff that's coursing through your body every single second?
Hmm.
Today, we're going to take a real deep dive into the complex, sometimes hidden world of your blood, looking at its functions, what it tells us about our health.
Yeah, and our mission today, really, is to unpack the secrets of this liquid that seems, well, pretty much the same in everyone, but actually isn't. It's unique.
Right.
We'll explore how blood acts as this dynamic indicator,
Hmm.
how healthcare professionals analyze it constantly to check your overall health, find infections, and we can diagnose diseases.
And we've got a good stack of sources to guide us through this exploration.
Exactly.
Okay, so to really get it, we need the basics first. What exactly is blood? I mean, beyond just red liquid.
Right. Well, at its core, blood is actually a liquid connective tissue. Think
Mhm.
of it like a busy river. It's got cells, cell fragments, all floating in this watery matrix called blood plasma. And the real genius of it is its vital role in maintaining homeostasis.
That's that perfect internal balance, right?
Exactly. Keeping everything stable inside your body. Blood basically has three main jobs, three general functions. And understanding these is, well, it's key.
So it's not just delivering stuff, it's like the ultimate multitasker, transporting, regulating, and protecting all at once.
Precisely.
That's kind of amazing. How does it manage all that? Can you break those functions down a bit?
Absolutely. So first up,
Yeah.
transportation.
Yeah.
It's your body's internal highway, like you said,
Ah,
constantly moving oxygen from your lungs out to every single cell. And then it picks up the carbon dioxide waste and carries it back to the lungs so you can breathe it out.
okay, standard delivery service.
But it's more than that. It also delivers nutrients from your gut after you eat, hormones from your glands.
Mm.
It even moves heat around and waste products to organs like your kidneys and skin so they can get rid of them.
So delivery and waste removal nonstop. Got it. What about the regulation part? You said it manages things.
Exactly. That's function number 2, regulation. Blood helps keep your body's pH level steady, right in that narrow, healthy range, using chemical buffers,
Like a chemical balancer.
pretty much.
Yeah.
And it helps adjust your body temperature. The water in plasma absorbs heat, and your body directs blood flow closer to or further from the skin to cool down or warm up.
Ah, clever.
And it influences the water content of your cells too, making sure they don't, swell up or shrink too much.
Okay, okay. And the third one was protection.
Yes, protection. This is crucial. Blood forms clots when you're injured, stopping excessive bleeding, like a rapid repair crew.
Right.
And it's white blood cells. They're the security force. They perform phagocytosis, basically engulfing nasty microbes. Plus, blood carries proteins like antibodies that fight off illness. It's a whole defense system.
So this stuff isn't just colored water. It has some really specific physical traits, doesn't it?
Oh, definitely. Blood is denser than water, and it's more viscous, thicker.
Stickier.
Yeah, slightly sticky. Its temperature is usually around 38 degrees C. That's about 100.4 degrees Fahrenheit, a little warmer than your oral temperature.
Okay.
Its pH is slightly alkaline, between 7.35 and 7.45. And the color tells a story: bright red when it's full of oxygen, darker red when it's dropped it off.
And how much blood do we actually have?
It makes up about 8% of your body mass. So for an average adult male, maybe 5 to 6 liters. That's around 1.5 gallons. For females, it's typically a bit less, 4 to 5 liters, mostly due to differences in average body size.
And it's all these little details, these numbers that doctors are looking at in blood tests, right? That whole field is hematology.
Exactly. Hematology.
Yeah.
That's the science focused entirely on blood, studying its components, how it works, what goes wrong. Those numbers tell a huge story about your health.
It's just amazing how complex the body is, even down to our blood. Okay, so to really appreciate it, let's unpack what it's actually made of. If you spin blood down in a centrifuge, what are we looking at?
Right. If you do that, you'll see it separate pretty clearly into two main parts. The top layer, which is about 55% of the volume, is the watery liquid part, blood plasma.
Mostly water, I guess?
Yep, about 91.5% water. But the other 8.5% is where loads of important stuff is dissolved. That's the solutes.
And the bottom layer?
The bottom layer, the other 45%, that's denser. It's all the cells and cell fragments. We call these the formed elements.
Okay, let's start with the plasma then. That 8.5% solutes. What's in there?
Well, the biggest chunk of that, about 7% by weight, is proteins, mostly made by your liver.
Proteins like?
Like albumins, they're the most common. Think of them as little sponges, maintaining osmotic pressure, keeping fluids balanced. Then you have globulins.
Globulins, I know that includes antibodies, right?
Exactly.
Yeah.
Immunoglobulins or antibodies are a type of globulin. They're key players in your immune response, targeting bacteria, viruses, you name it. Other globulins transport things like iron and vitamins.
Okay. Any other big proteins?
And then there's fibrinogen, absolutely essential for blood clotting. It forms the mesh that makes a clot.
Wow. Okay. So proteins are key. What else is dissolved in that plasma?
The last 1.5% or so is a real mix. You've got electrolytes, sodium, potassium, calcium vital for nerves and muscles,
Uh-huh.
nutrients like glucose, amino acids, fatty acids, fuel for your cells. Gases are dissolved in there too, like O2, CO2. Regulatory substances, enzymes, hormones, vitamins, and finally waste products like urea heading for removal. It's a busy soup.
It really is. And the formed elements, the cells, you said mostly red blood cells.
Overwhelmingly, more than 99% of the formed elements are red blood cells,
Yeah.
RBCs. They're what give blood its color.
Than the rest. That tiny fraction.
Less than 1% is made up of white blood cells, WCs, and platelets. When you centrifuge blood, they form this thin, pale layer called the buffy coat between the plasma and the red cells.
Right. Okay. So red blood cells, they're obviously iconic, but their job is way more interesting than just being red, isn't it? Real workhorses.
They absolutely are. True microscopic workhorses.
Yeah.
Let's look at their structure first. They're called erythrocytes, and they have this unique shape, a biconcave disc.
Like a donut that's swished in the middle.
Exactly.
Yeah.
That shape is brilliant because it maximizes the surface area for gases like oxygen to diffuse in and out quickly.
Clever design.
And what's really fascinating is that mature red blood cells actually kick out their nucleus and most other organelles.
No nucleus, so they can't divide or fix themselves much.
Right. They can't reproduce or do complex metabolism. But crucially, this also means they don't use up the oxygen they carry. They're purely for delivery.
Dedicated couriers. And the key to that delivery is hemoglobin.
Hemoglobin, yes. Each tiny red blood cell is crammed with about 280 million hemoglobin molecules.
Wow, 280 million.
Yeah, it's packed.
Yeah.
And each hemoglobin molecule is complex. It's got 4 parts, and each part has an iron ion at its center.
And the iron grabs the oxygen.
Exactly. The iron ion, Fe2+, acts like a tiny magnet that reversibly binds to one oxygen molecule. So one hemoglobin carries 4 oxygens.
So the main job is obvious oxygen transport, lungs to cells.
That's job number 1. But it also carries about 23% of the carbon dioxide waste back from your cells to your lungs. That binds to a different part of the hemoglobin, not the iron.
Okay, so O2 and CO2 transport, but I think you mentioned something surprising before. Hemoglobin affecting blood flow.
Yes, that's a really neat function. Hemoglobin can also bind to nitric oxide, which is a gaseous hormone.
Mm-hmm.
When hemoglobin releases this nitric oxide, especially in your tissues that need oxygen, it causes the blood vessels nearby to relax and widen. That's called vasodilation.
So it helps open up the pipes where oxygen is needed most.
Precisely. It improves blood flow and oxygen delivery right where it counts. And there's another trick. RBCs have an enzyme called carbonic anhydrase.
Hey, what does that do?
This enzyme helps convert CO2 and water into carbonic acid, which then breaks down. This reaction is super important because it allows about 70% of your CO2 waste to travel dissolved in the plasma as bicarbonate ions. Much more efficient.
And helps with pH too, you said.
Yes, it's also a key part of the blood's buffering system, helping keep that pH stable.
These cells are doing so much work, but they don't live forever, do they? What's their lifespan like?
No, they have a limited run, only about 120 days.
4 months, roughly.
Right. As they age, their outer membrane gets fragile, especially from squeezing through tiny capillaries over and over.
So what happens to the old ones?
They get recycled. Specialized cells called macrophages, mostly in the spleen and liver, basically engulf and break down the worn-out RBCs.
And the body recycles the parts? That sounds efficient.
Incredibly efficient. The protein part, the globin, is broken down into amino acids, which the body reuses to build new proteins.
And the iron, that's precious stuff.
Absolutely. The iron is carefully removed from the heme group. It gets escorted by a transport protein called transferrin, and then stored, mainly in the liver, attached to a storage protein called ferritin.
Ready to be used again.
Exactly. It's reused to make new hemoglobin, along with those recycled amino acids and vitamin B12. The rest of the heme group, the non-iron part, gets converted into waste products. First biliverdin, then bilirubin.
Bilirubin. That rings bell. Jaundice.
Yes, bilirubin goes to the liver, gets put into bile, and eventually ends up coloring your urine yellow and your feces brown. If that process breaks down, bilirubin builds up, causing jaundice.
It's such a neat recycling system. But what if you get too much iron? You mentioned storage. Can that overflow?
It can. That's a condition called iron overload. If those transport and storage proteins, transferrin and ferritin, get saturated, you can end up with free iron floating around.
And that's bad.
Very bad. Free iron is toxic. It can damage tissues and organs like the liver, heart, pancreas. It also creates an environment where some bacteria can thrive.
Another example of how balance is key. So how does the body make new red blood cells? What's that process?
That process is called erythropoiesis. It happens continuously in your red bone marrow.
Starts in the marrow, okay.
It begins with precursor cells called proerythroblasts. They divide, multiply, and start making hemoglobin. Then, crucially, the developing cell ejects its nucleus.
It throws out its control center.
Yep, becomes something called a reticulocyte. These reticulocytes then squeeze out of the bone marrow into the bloodstream and mature into fully functional red blood cells within about a day or two.
And how does the body know when to make more? Is there a signal?
There is, and it's a really elegant negative feedback loop. If your blood's oxygen levels drop too low, that's called hypoxia. Specialized cells in your kidneys detect it.
The kidneys. Interesting.
Yeah, the kidneys then release a hormone called erythropoietin, or EPO.
Ah, EPO. I've heard of that.
EPO travels through the blood to the red bone marrow and basically tells it, hey, step up production. It stimulates those precursor cells to develop faster into reticulocytes, boosting your red blood cell count and restoring oxygen capacity.
So doctors can measure this, that reticulocyte count you mentioned.
Exactly. A reticulocyte count tells us how quickly your bone marrow is churning out new red blood cells. If it's low when someone's anemic, maybe there's a problem with EPO or the marrow isn't responding.
And if it's high?
A high count usually means the marrow is working hard, maybe responding to recent blood loss or if someone started iron supplements.
This also relates to blood doping in sports, doesn't it? Using EPO.
Yes, unfortunately. Some athletes illegally inject synthetic EPO, essentially tricking their bodies into making way too many red blood cells.
To carry more oxygen, get an edge.
Right. But it's incredibly dangerous. It makes the blood thick, sludgy almost, increases blood pressure, forces the heart to work way harder, and dramatically raises the risk of stroke or heart attack.
Not worth the risk. How is that different from altitude training?
Completely different. Altitude training, like what many elite runners do, is a natural adaptation. Training at high altitude, where there's less oxygen, triggers your body to naturally produce more EPO and more red blood cells over time. It's a safe physiological response.
Got it. Okay, so RBCs are the oxygen couriers. Let's switch gears to the defenders, the white blood cells. Fewer of them, but critical for immunity, right?
Absolutely critical. These are your leukocytes. Unlike RBCs, they have a nucleus, all the standard organelles, but no hemoglobin.
And they're not all the same, are they?
No, they're classified into two main groups based on whether they have visible granules in their cytoplasm under a microscope. The granular ones are neutrophils, eosinophils, and basophils. The agranular ones are lymphocytes and monocytes.
And their main job overall?
Your overall mission is defense, fighting off infections, microbes, foreign substances, dealing with inflammation.
Do they stay in the blood mostly?
Actually, no. Most WBCs do their work outside the bloodstream, in the tissues where infections happen.
How do they get out?
They have this amazing ability called emigration, or diapedesis. They literally squeeze themselves between the endothelial cells that line the blood vessels.
Wow, like escape artists.
Pretty much. And once they're in the tissues, they follow chemical trails released by microbes or damaged cells to find the site of infection. That's called chemotaxis.
Like following a scent. Okay, so let's talk about the different types. You mentioned neutrophils are the most common.
Yes. Neutrophils make up about 60–70% of your circulating WBCs. They're the first responders, especially to bacterial infections.
What do they do?
They're expert phagocytes. They engulf and destroy bacteria. They also release powerful chemicals, including enzymes like lysozyme and strong oxidants. Think substances similar to bleach, but on a micro scale. Plus, proteins called defensins that poke holes in microbes.
Intense. What about the others? Eosinophils.
Eosinophils, 2–4%, are important in fighting parasitic worms and also play a big role in allergic reactions, helping to counteract histamine. High levels often point towards allergies or parasites.
Okay. And basophils, you said they're rare.
Very rare, less than 1%. Basophils leave the blood vessels and release histamine, heparin, and serotonin in tissues. These chemicals intensify inflammation and allergic responses. They work very closely with mast cells.
Got it. Now the agranular ones, lymphocytes sound important.
Oh, hugely important. Lymphocytes, 20–25%, are the major players in your specific immune responses. Most of them hang out in lymphatic tissues like lymph nodes and the spleen, only circulating in blood for short periods.
And there are different kinds of lymphocytes.
Yes. B cells are responsible for making antibodies, those specific proteins that target bacteria and toxins. T cells directly attack body cells that are infected with viruses or become cancerous. They're also involved in transplant rejection. And then natural killer, NK cells, provide more general surveillance, killing off infected cells and some tumor cells without needing prior sensitization.
A whole army. What about the last type? Monocytes.
Monocytes, 3 to 8%, are the largest type of WBC. They take a bit longer to arrive at an infection site than neutrophils, but they arrive in larger numbers and are more powerful.
What do they do when they get there?
They enlarge and transform into macrophages. These are the big eaters, the major cleanup crew. They have phagocytocellular debris, microbes, worn-out cells after the battle is over. Some are fixed in specific tissues, others wander around.
It's incredible coordination. And you mentioned something about identity markers on these cells.
Yes, a really important concept. White blood cells, and actually all your body cells with a nucleus, have proteins on their surface called major histocompatibility complex, MHC, antigens.
MHC.
Okay, these are unique to you, like a cellular fingerprint, unless you have an identical twin. They allow your immune system to recognize self, your own cells, versus non-self, like bacteria or transplanted organs.
Which is obviously critical for immune function and transplants. So looking at WBC counts must be really useful for doctors.
Absolutely vital. A high WBC count, called leukocytosis, usually means the body is fighting something off: infection, inflammation, even responding to intense stress. It's generally a protective response.
And a low count?
That's leukopenia. An abnormally low count is never good. It can be caused by things like radiation, certain drugs, or shock, and it leaves you vulnerable to infection.
Is there a test that breaks down the types?
Yes, and it's one of the most common and informative blood tests. The differential white blood cell count, often just called a DIF.
Oh, the DIF.
It measures the percentage of each of the 5 types of WBCs. A shift in those percentages gives huge clues. High neutrophils might suggest a bacterial infection. High eosinophils may be allergies or parasites. High lymphocytes, perhaps a viral infection. It helps diagnose all sorts of things and monitor treatments.
Okay, we've covered oxygen carriers, defenders. What about the platelets? The tiny fragments involved in clotting? The rapid response construction crew, you called them?
Yes, that's a good way to think of them. Platelets or thrombocytes. They aren't whole cells, but rather irregular disc-shaped fragments.
Fragments of what?
They break off from enormous cells in the bone marrow called megakaryocytes. One megakaryocyte can shatter into thousands of platelets. They have vesicles full of chemicals, but no nucleus.
How many are floating around?
A lot. Normal counts are anywhere from 150,000 to 400,000 per microliter of blood, but they don't live long.
How long?
Only about 5 to 9 days. The macrophages remove the old ones.
And their main job is?
Their primary role is in hemostasis, stopping bleeding. They release chemicals that kick off the clotting cascade, and they clump together to form a temporary platelet plug at the site of injury.
Is their production regulated too?
Yes, by a hormone called thrombopoietin, or TPO, which is mostly made in the liver.
Okay. And this all ties into that common test, the CBC.
Exactly. The complete blood count, CBC, gives you counts for red cells, white cells, and platelets, plus hemoglobin levels and other measures. It's a fantastic overall screening tool for blood health.
So platelets are key for stopping bleeding. Let's get into that process. Hemostasis, which you stressed is different from homeostasis.
Crucial distinction, yes.
Okay.
Hemostasis is specifically about stopping bleeding quickly and locally when a vessel is damaged. It's a rapid sequence involving 3 main overlapping steps.
Okay, step 1.
Vascular spasm. When an artery or smaller arteriole is cut, the smooth muscle in its wall contracts almost instantly.
It clamps down.
Exactly. It narrows the opening, significantly reducing blood flow. This can last for minutes to hours and is triggered by the injury itself, chemicals released by platelets, and pain signals.
Okay, so the vessel constricts. What's next to plug the hole?
Step 2, platelet plug formation. This happens very quickly. First, platelet adhesion. Platelets floating by encounter the damaged vessel wall, especially exposed collagen fibers underneath the normal lining, and they stick to it.
They grab on.
Right. And sticking activates them. They change shape, extend little projections, and undergo the platelet release reaction. They dump the contents of their internal vesicles.
What kind of stuff do they release?
Key things like ADP and thromboxane A2, these act like alarm signals, activating other nearby platelets and making them sticky too. Serotonin and thromboxane A2 also enhance that vascular spasm, the clamping down. They also release things like platelet-derived growth factor, PDGF, which helps later with healing the vessel wall.
So they call for backup and make themselves sticky.
Pretty much. The released ADP causes platelet aggregation. More and more sticky platelets pile onto the site, sticking to each other, forming a mass, the platelet plug. For small tears, this plug alone might be enough to stop the bleeding.
But for bigger injuries, you need more. That leads to step 3.
Yes, step 3 is blood clotting, also known as coagulation. This is the most complex but strongest step. It results in the formation of a gel-like clot.
A gel.
Essentially, yeah. It's a meshwork of insoluble protein fibers called fibrin. This fibrin net traps red blood cells, white blood cells, and more platelets, forming a stable, robust seal over the damage.
How does that fibrin form? Is it complicated?
It involves a cascade, a series of chemical reactions involving numerous clotting factors. These are mostly inactive enzymes made by the liver, calcium ions, and molecules from platelets in damaged tissues. We number them with Roman numerals.
A cascade. Like dominoes falling.
That's a great analogy. One factor activates the next, which activates the next. We can break it down into 3 main stages.
Okay, give us the simplified version, stage 1.
Stage 1 is forming a crucial enzyme complex called prothrombinase. This can happen via 2 main routes. The extrinsic pathway is fast, triggered by tissue damage outside the blood vessel, releasing something called tissue factor. The intrinsic pathway is slower, triggered by damage inside the vessel, like contact with collagen. Both paths lead to prothrombinase.
Okay, prothrombinase is formed. Stage 2.
Stage 2. Prothrombinase, along with calcium, converts a plasma protein called prothrombin into the active enzyme thrombin.
Thrombin. That sounds important.
It is the key enzyme. Stage 3. Thrombin, again needing calcium, acts on another soluble plasma protein, fibrinogen, and converts it into those insoluble fibrin threads.
And those fibrin threads make the clot mesh.
Exactly. They weave together, trapping cells, forming the stable clot. Thrombin also does a couple of other things. It activates a factor that strengthens the fibrin mesh, and it actually feeds back to speed up its own formation.
A positive feedback loop to make the clot form faster.
Precisely. It amplifies the process quickly, and once the clot is formed, it undergoes clot retraction.
Shrink.
Sort of tightens up. The platelets trapped in the fibrin mesh actually pull on the fibrin threads, drawing the damaged edges of the blood vessel closer together, like stitching it shut from the inside. Serum, the plasma, minus clotting factors might ooze out, but the cells stay trapped.
And vitamin K is important here somewhere.
Absolutely essential. Your liver needs vitamin K to synthesize 4 of the key clotting factors, including prothrombin. Without enough vitamin K, your blood doesn't clot properly.
Okay, that's how we stop bleeding. But the body must have ways to stop clots from forming when they're not needed, or get rid of them once healing happens. You don't want random clots.
Excellent point. Yes, there are sophisticated control mechanisms. There's a process called fibrinolysis, which is basically clot dissolution.
Breaking down the fibrin.
Exactly. An inactive plasma protein called plasminogen gets woven into the clot as it forms. Later, substances released from healing tissues activate plasminogen into plasmin. Plasmin is an enzyme that acts like molecular scissors, chopping up the fibrin threads and dissolving the clot once the damage is repaired.
So a built-in demolition crew.
Right. And your blood also contains natural anticoagulants, substances that actively work against clotting. Antithrombin blocks the action of thrombin and other factors. Heparin, released by certain white blood cells, boosts antithrombin's activity. There are others too, like activated protein C. Even the cells lining healthy blood vessels produce things like prostacyclin that inhibit platelets from sticking.
But sometimes clots do form where they shouldn't, right? Inside unbroken vessels.
Unfortunately, yes. That's called thrombosis. It can happen if the vessel lining is roughened, maybe due to atherosclerosis, or if blood flow becomes very sluggish, called stasis.
And if that clot breaks loose.
If a clot or a piece of it, or even an air bubble or fat globule breaks free and travels through the bloodstream, it's called an embolus. If it gets stuck somewhere critical, like the lungs, pulmonary embolism, or brain, it can be life-threatening.
That's where things like aspirin come in.
Yes. Low-dose aspirin helps prevent clots by inhibiting platelet aggregation. It's often used for people at risk of heart attack or stroke. And for clots that have already formed and are causing problems, doctors can use powerful clot-busting drugs, thrombolytic agents like TPA, to dissolve them quickly.
Okay, this is all incredibly complex. And on top of all these functions, you said blood is unique to each person. How do we categorize that, and why is it so vital for transfusions?
It is unique, based on markers on your red blood cells. These markers are antigens, specifically called agglutinogens, made of glycoproteins and glycolipids. Your specific combination of these antigens determines your blood type.
And there are many types.
Loads. At least 24 major blood group systems are known, with hundreds of antigens. But the most important ones clinically are the ABO and RH groups.
Let's start with ABO. That's A, B, AB, and O, right? What do those mean?
Exactly. It's based on whether your red cells have antigen A, antigen B, both, or neither.
So type A has A antigen.
Correct. Type B is only B. Type AB has both A and B antigens, and type O has neither A nor B antigen on the red cell surface.
Okay, that seems straightforward. But there's something about antibodies in the plasma, too.
Yes, and this is the crucial part for transfusions. Your plasma naturally contains antibodies, called agglutinins, that react against the ABO antigens you don't have.
So if I'm type A, I have.
If you're type A with A antigens, your plasma has anti-B antibodies. If you're type B, you have anti-A antibodies. Type AB folks have neither antibody. And type O people, lacking A and B antigens, have both anti-A and anti-B antibodies. These appear naturally a few months after birth.
Ah, okay. This is where universal donor and universal recipient come from.
That's the idea, yes. Type O individuals are called universal donors because their red cells lack A and B antigens, so in theory, they won't trigger a reaction from the recipient's antibodies.
And type AB?
Type AB individuals are called universal recipients because they lack both anti-A and anti-B antibodies in their plasma, so theoretically they can receive red cells from any ABO type.
But you said theoretically.
Exactly. It's a simplification. In real practice, even for O-negative blood, OA and RH negative, we always do cross-matching before a transfusion to check for reactions against other, less common blood group antigens. Safety first.
Got it. What about the RH factor, the positive or negative part?
The RH blood group is based on the presence or absence of another key antigen, the RH antigen or RH factor, first found in rhesus monkeys.
So RH positive means you have it.
Yes, if your red cells have the RH antigen, you're RH positive, RH plus. If they don't, you're RH negative.
Do RH negative people have anti-RH antibodies naturally?
No, not normally. Unlike the ABO system, anti-RH antibodies only develop if an RH negative person is exposed to RH positive blood.
How would that happen?
Usually through an incompatible blood transfusion, or more commonly during pregnancy, if an Rh negative mother carries an Rh positive baby.
Okay, so why is matching blood types so incredibly important for transfusions? What goes wrong if it's mismatched?
If incompatible blood is transfused, it can cause a severe transfusion reaction. The recipient's antibodies, like anti-A in a type B person getting type A blood, attack the donated red blood cells.
Attack how?
They cause the donated cells to agglutinate or clump together. This isn't clotting, it's an antigen-antibody reaction. This clumping can block small blood vessels, but worse, it triggers other immune responses that lead to hemolysis, the rupture of the red blood cells.
And ruptured red cells are bad because
They release all that hemoglobin into the plasma. Free hemoglobin is toxic to the kidneys and can cause kidney failure. Plus, there's always a very small risk of transmitting infections, though screening is extremely rigorous now.
you mentioned pregnancy, that Rh incompatibility can cause problems there too.
Yes, that leads to hemolytic disease of the newborn, HDN. It happens when an Rh negative mother is pregnant with an Rh positive fetus.
How does that work?
During the first pregnancy, especially around delivery, some of the baby's Rh plus red blood cells can leak into the mother's Rh circulation. Her immune system sees the Rh antigen as foreign and starts making anti-Rh antibodies.
But the first baby is usually okay.
Usually, yes, because the sensitization happens late. But the mother now has those anti-Rh antibodies.
Sure.
If she gets pregnant again with another Rh plus fetus, her antibodies can cross the placenta and attack the second baby's red blood cells, causing hemolysis. This could lead to severe anemia, jaundice, even brain damage or death for the baby.
That sounds awful. Can it be prevented?
Yes, absolutely. There's an injection called RhoGAM. It contains anti-Rh antibodies.
So you give antibodies to prevent making antibodies. How does that work?
It sounds counterintuitive, but the injected RhoGAM antibodies find and neutralize any fetal Rh plus cells that might have entered the mother's blood before her own immune system gets activated. It essentially mops them up quietly, preventing her from becoming sensitized and making her own long-lasting antibodies. It's given during pregnancy and after delivery to our mothers.
Amazing. So before any transfusion, the lab does careful checking, typing, and cross-matching.
Always. Typing determines the patient's ABO and Rh type by mixing their blood with known anti-sera and looking for clumping. Cross-matching is the final safety check. Mixing a sample of the donor's red cells with the patient's plasma to make absolutely sure there's no reaction. We also use anticoagulants like heparin or warfarin therapeutically for patients prone to clots, and substances like EDTA or CPD are added to donated blood bags to prevent clotting during storage by binding calcium.
It's a remarkably complex and well-managed system. But like any system, things can go wrong. Let's touch briefly on some common blood disorders. Anemia seems like a big one.
It is very common. Anemia isn't one single disease, but rather a condition where the blood just doesn't carry enough oxygen.
Why would that happen?
Either not enough red blood cells or the red blood cells don't have enough functional hemoglobin. The result is usually fatigue, feeling cold, maybe looking pale.
Are there different causes?
Many. Iron deficiency anemia is probably the most common worldwide, from poor diet or blood loss. You can have anemias from lack of vitamin B12 or folic acid, megaloblastic anemia, or inability to absorb B12, pernicious anemia. Hemorrhagic anemia is from excessive bleeding. Hemolytic anemias are when red cells break down too fast. There are inherited conditions like thalassemia affecting hemoglobin production, or aplastic anemia where the bone marrow itself fails.
Lots of ways for oxygen transport to fail. What about sickle cell disease? That sounds different.
It is. Sickle cell disease, SCD, is an inherited disorder where a faulty gene causes abnormal hemoglobin called HBS.
What does that do to the cells?
When HBS releases oxygen, it makes the red blood cells deform into a rigid crescent or sickle shape. These sickled cells don't flow well. They can block small vessels, causing intense pain crises. They also break down much faster, leading to chronic anemia and potential organ damage.
But I heard there's a connection to malaria.
Yes, fascinatingly, carrying just one copy of the sickle cell gene provides significant protection against malaria. That evolutionary advantage explains why the gene is more common in people with ancestry from malaria-prone regions.
Wow. What about problems with clotting? Like hemophilia?
Hemophilia is another inherited disorder, but this one affects clotting factors. People with hemophilia lack sufficient amounts of certain factors needed for the coagulation cascade.
So they bleed easily.
Yes, they can experience spontaneous bleeding or bleed excessively after even minor injuries. It used to be devastating, but now it's manageable with regular infusions of the missing clotting factor.
And finally, cancers of the blood system, leukemia.
Leukemia refers to a group of cancers that start in the red bone marrow, the blood-forming tissue. It involves the uncontrolled production of abnormal white blood cells.
How does that cause problems?
These abnormal cells crowd out the normal blood cell production. So you end up with too few healthy red cells, causing anemia, too few healthy white cells, leading to infections, and too few platelets, causing bleeding problems. Symptoms often include fatigue, weight loss, fever, easy bruising, and frequent infections. They're classified based on how fast they progress, acute or chronic, and which type of white blood cell is affected.
What an absolutely incredible journey through our blood, from, the basic stuff it's made of and what it does every day to these amazing defense systems, the clotting, the fact that it's unique to each of us. It really is a river of life, isn't it?
It truly is. And if you think about the big picture,
Mm.
just how vital and perfectly balanced every single tiny component has to be,
Mhm.
it really highlights the hidden complexity, the resilience of our bodies, doesn't it? Even in processes we completely take for granted.
Yeah, it's mind-boggling. Maybe the next time you hear about a blood test or, even just see a drop of blood from a paper cut, you'll see it a bit differently. This constantly moving, totally personal, endlessly fascinating river carrying life through you.